You should. All right. You should be good to go.
All right. Good morning, everyone. Thanks for having me on this morning. So today we're going to talk about elbow and wrist injuries. Really focus on like soft tissue issues. So no, we're not going to cover any like fractures. I know recently I had a hand lecture, Dr. Goldberg, and I believe Dr. Briskin did a peripheral neuropathy. So there might be some overlap, but I think it's still important to kind of cover these topics. A lot of times in clinic, we're seeing a lot of knee, hip, shoulder, and maybe not as much wrist, elbow injuries. So it's good to kind of get this at least from a lecture standpoint. So as you're preparing for boards, you have something that you can kind of fall back on. So today, again, we're just going to review some elbow injuries, wrist injuries, and if there's time at the end, we'll do a few CAQ questions. So today, as far as the elbow goes, epicondylopathy, UCL sprain, a variety of nerve impingements, distal bicep injuries, elbow impingement, and then lastly, olecranon bursitis, which I know is not really a classic injury per se, but I would say outside of epicondylopathy, it's probably the most common thing that I'm seeing patients refer to my clinic for. So if you're to a review of that would be helpful. So brief kind of just anatomy overview. So your elbow is a hinge joint, I'm sure you're well aware. Flexion, we look to get 150 degrees. The primary elbow flexor when you're pronated is your brachialis. When you're supinated, it's the biceps brachii. With extension, the triceps is your primary extender. Pronation and supination are about 80 and 80 degrees respectively. The elbow joint's made up of three different articulations: ulnar-humeral, radiocapitellar, as well as the proximal radio-ulnar. And then on each side of the elbow, you have the ligament complexes. The more important one that we'll talk about a little bit later with the UCL sprain is that medial collateral ligament complex, which then is further subdivided into a few different bands. And then from an ultrasound standpoint, I don't think you guys yet done the ultrasound, but the top left corner is going to be the home base. So looking at the anterior approach, brachioradialis, the lateral side with your radian nerve right here. Your biceps tendon sits superficially. Your brachialis is deep. This is your the articular cartilage. Your pronator teres, and then your median nerve sits right here. From a posterior view, you can see the triceps, olecranon. If you do have a really olecranon bursitis, you'll see it collect right here. From the medial viewpoint, you can see the medial epicondyle. You see your UCL, your flexor tendon, and the joint space. One way to think about this is like a 50-40-10 split. So the top 50% is going to be that common flexor tendon. The next 40% is going to be the UCL. And then 10%, that's the very bottom portion, is going to be the joint space. Opposite goes for the lateral side with your common extensor tendon, lateral epicondyle, lateral collateral ligaments, and then your joint space down here. So to begin, epicondylopathy, obviously this is probably the most common elbow complaint that we will see, at least in the adult side of things. So for the lateral epicondyle, the origin of the common extensor tendon, with the ECRB being the most common tendon involved. The medial epicondyle, you're going to have the common flexor tendon. The way I counsel patients for this particular disease is that it's an elbow pain, but a wrist problem. So patent pending on that. And what I always try to explain to them is, even though everyone feels the pain at the elbow, it's coming from the involvement and the overuse of the wrist. And that's why in a few minutes we talk about treatment. Sometimes it is immobilizing the wrist to address this issue. And really what's causing it is the repetitive loading leading to inflammation and ultimately micro tearing, causing pain and dysfunction. And as you're well aware, kind of the epicondylopathy, you can kind of splice that out into either epicondylitis, so that more of acute kind of 0 to 3 month inflammation, and then epicondylosis, going past that 3 month, more of a chronic issue. On the lateral side, as well, where as we call it, tennis elbow, medial side, the golfer's elbow. Risk factors on the lateral side, a lot of racket sports, heavy tool use, repetitive, it's a lot of mechanics. You'll see laborers that will come in with these complaints. It's a lot more frequent than medial side. About 5% of the population annually will deal with this. On the medial side, again, males and females equally affected, but it's much less common than lateral side. The biggest risk factors are repetitive forearm pronation. So like with a golfer's swing when they're coming through after striking the ball and following through, or another sport like bowling when you're releasing the ball and following through, puts a lot of increased stress on the medial aspect of the elbow. As far as exam goes, the biggest thing that you're looking for is very focal tenderness at that lateral epicondyle in the proximal common extensor tendon. As we'll talk about in a few minutes, some other injuries to consider. If they're really not tender at the lateral epicondyle, you may want to broaden the differential. That's the most specific finding. The pain's going to get worse with increased supination and wrist extension. You can also perform what's called a Maudsley's test, which is you have them actively resist middle finger extension while you're isolating at the lateral epicondyle, and if that reproduces the symptoms, that's considered a positive test. For golfer's elbow, it's kind of the opposite. You're going to have focal tenderness, the medial epicondyle, and the common flexor tendon, which is going to get worse with increased wrist pronation and flexion. While this is a clinical diagnosis, some things from a radiographic standpoint can aid in it. For an X-ray, you may see an enthesiophyte developing over the epicondyle. If an MRI is obtained, you can see tendon tearing as well as increased T2 signaling at the insertion site, as you can see here. And then lastly, with ultrasound, if you're scanning in clinic, you might see a thickened appearance of the tendon insertion, areas of hypoechogenicity indicating some partial tearing. And again, sometimes you can also see some enthesiophytes develop. Whether it's lateral epicondyle or medial epicondyle, rehab is really going to be the biggest thing to correct this. A lot of people come in and just want the pain resolved, but when I'm counseling them and telling them if you don't fix the mechanics that are causing this, from the bottom up, this is going to continue to recur. And this is where that explanation of wrist pain, but elbow pain, but wrist problem comes into play. It's thought with the repetitive wrist extension and flexion, whether it's with sports or even just day in and day out, you're grabbing things out of your car, case of water. It's real heavy, putting a lot of increased strain on those smaller wrist tendons, which then leads to pain at their origin site at the elbow. So one of the things I counsel patients, if you're lifting probably more than like 5 or 10 pounds in that hand, you really should use your arm more of like a scooping mechanism, activate your biceps, your triceps, the bigger, heavier muscles to do the lifting, and you're putting less strain at the wrist. Modifications, outside of gripping, lifting mechanics. If they're using a tennis racket or a pickleball racket, you can add grip width to it, so you don't have to compress as much. If you're like a bowler, you can use lighter weights. Counterforce bracing, as you can see, that the Bandit brace is the one we typically recommend. That's placed about 2 to 3 centimeters below the elbow joint. What that's trying to do is kind of shift the fulcrum point of those tendons away from their insertion site to offload. You also can consider wrist immobilization. This is not something I jumped to initially, but if they're really recalcitrant, if you immobilize the wrist, that can also offload that further. And that's just like a basic neutral wrist brace. As far as adjunctive treatments, corticosteroid, pretty controversial. If someone's coming in with more of an acute process and they've taken the oral NSAIDs or topical NSAID and they're not responding, I do offer them patients this, and you just kind of counsel them that, hey, in the short term, this is going to give you relief, but there's a high likelihood that it's going to recur, about 60% within a year. And then I tell them, hey, this is on a site that we want to continue to inject steroid with. Overall, it's going to deteriorate the tendon and put you at risk for a tendon rupture. And that's where things like PRP come into play. So if there's someone that's having more of a chronic tendinopathy, or this kind of continues to recur, this is something I recommend. A multiple systematic review show it's more effective in the long-term relief. Anecdotally, I would say about 95% of the patients that I do a PRP on for the lateral epicondyle or medial epicondyle get a positive response. And it might not make them pain-free, but I would say most come back and say, hey, that sharp, severe pain's gone. Maybe it's a dull ache that's not limiting their functioning. Of all the things I do PRP for, I would say this has the highest response rate, again, anecdotally. There's also data that ESWT, so shockwave therapy, is beneficial. At Drzezinski, at the Sports Medicine Institute, as well as T3 and Avon, they do offer this. It's about $75 a session. Typically, it's about 3 to 5 sessions are needed to receive benefit. So you have patients that come into you and ask you about this. And then lastly, there's percutaneous tenotomy or 10X. And if that fails, upper extremity surgeons can do a surgical tendon debridement. But I would say most surgeons that I've worked with here, they really want us to exhaust kind of everything else before they will go and do the release here. So that's definitely something that's in our wheelhouse to manage from the primary care standpoint. Moving on with the UCL sprain. As mentioned, on the medial complex, there's an anterior band, a posterior band, and a transverse band. And the anterior band then splits onto an anterior and posterior, with the anterior band of the anterior oblique ligament being the most important one from a physiological standpoint, as the primary stabilizer to valgus stress. And this is what's typically torn when someone has this particular injury. So with risk factors, overhead throwers, classically baseball pitchers is what we think about. High velocity, high volume. So it's those year-round athletes, travel teams that aren't taking breaks. The incidence in teenage and youth is really skyrocketing because of this. So historically, it's been kind of college and professional athletes we're seeing, but I would say at least probably 3 to 5 times a year, I'm seeing high school kids coming in with these injuries. Also, weak kinetic chain. So if they're relying a lot on their shoulder and arm to throw, opposed to using their core and legs to push off, they're going to have a higher risk of this injury. From an acute standpoint, they'll likely complain of hearing a pop, followed by pain and difficulty continuing to throw. From a chronic injury, those kind of complain of like a vague pain on the medial aspect of their elbow that tends to worsen in the late cocking, as well as the acceleration phases, as they start to kind of put that increased strain onto the medial aspect. And then as they try to throw, they'll have decreasing velocity, and they may have some associated ulnar paresthesias given the close proximity to the ulnar nerve. So on presentation, they're talking about pain and tenderness over the UCL. 3 tests that we can be used in clinic. One is just a basic valgus stress test. The second one is your milking maneuver, which can be seen on the left picture there, where you basically stabilize their elbow. You want to palpate over that joint space, and then you pull on their thumb and see if that elicits pain or increases laxity. You want to compare it to the contralateral side. And then you also can perform the moving valgus stress test, which is seen on the right-hand side of the screen, which is the most specific test for UCL injury. It's almost a combination of the milking maneuver and a valgus stress test, where you kind of arch them through a range of motion between 70 and 120 degrees while pulling back on their thumb. If this increases pain or laxity, that's considered a positive test. With imaging, x-rays are typically be normal. However, with more chronic injuries, you may see some calcifications developing or loose bodies. An MRI, classically, it was an MR arthrogram to increase the sensitivity and specificity. But now with today's machines, typically that's not necessary unless you're highly suspicious for a tear, and a regular MRI comes back as a normal appearance. With acute findings, we're typically going to see mid-substance tears versus avulsions from the ulnar insertion. With chronic, you're going to see kind of thickened ligaments, calcifications, and partial tearing. This is also something I would highly recommend if you're concerned with this, doing a dynamic ultrasound in clinic. It's very simple. You put the probe over the joint space, do a valgus stress, and see if that will open up. I would say when I have a high suspicion, I'll do the dynamic scan in clinic. And if it's stable, it doesn't mean I'm not going to get an MRI, especially if it's like an athlete that's in season. But it's a lot of reassuring initially that you can give them. First, if you do see some of the fibers start to open up, you see that joint space not have a firm endpoint, that definitely puts you at heightened suspicion for more severe injury. As far as kind of treatment, it varies based on kind of what the return to play is, or if there is a return to play. If I happen to have like an injury where I fell and got my elbow kind of pulled back and I tore my UCL right now, I wouldn't be getting my a UCL surgery. I would just manage it non-operatively. But if someone's a young athlete wants to get back, especially if they're a throwing athlete, there's a possibility they will need surgical reconstruction. For partial tears, the management is going to be rest, rehabilitation, working on forearm strengthening, and then a return to throwing program. If they're having associated cubital tunnel syndrome, you can also do a perineural CSI with ultrasound guidance to address that component. PRP injections have shown pretty good promise in as far as addressing the partial tears. In 2021, there was a cohort study. 60% of the patients were able to return to pre-injury levels. Now that number is kind of affected because there's about I want to say it was 12, about a dozen athletes that had like what they consider a grade 4 tear, which was tears at multiple sites that went on to require surgery. So I wouldn't expect PRP to work in a full thickness tear, but some of these like kind of grade 1 where there's edema, or even like a grade 2 with some partial tearing. I've had, anecdotally had some positive responses getting athletes back to return within a few months. And then there was also a follow-up study in 2024 that had a bigger population they reviewed and had about 75% return to throwing within 3 months. If there is a complete tear, or if they failed partial non-operative management partial tears, then they go on to have a UCL reconstruction, also known as the kind of the Tommy John surgery. So interestingly enough, Tommy John has the picture there. He actually, so he's the first surgeon that's ever had this. He actually went on to win more baseball games after his surgery than prior to the surgery. And I want to say he has the most professional wins in Major League Baseball history without being elected to the Hall of Fame. So some fun trivia there for you. Moving on with cubital tunnel syndrome. This is going to be a compressive neuropathy of the ulnar nerve. More common in men in their 50s and 60s. There's a couple of different sites where it can be compressed. Most commonly, it's going to be between the two heads of the FCU. Other considerations are within the arcade of Struthers and then the Osborne ligament and MCL. Complaints from kind of pain and paresthesias throughout the ulnar side of the forearm, extending into the 4th and 5th digits. Symptoms may increase at night. Explain it to patients. We all sleep in kind of our fetal position, and as we have that, deep, flexion of the elbow, that ulnar nerve can get compressed against the medial epicondyle to aggravate it. It's a clinical diagnosis with a positive Tinel's at the cubital tunnel, as well as intrinsic muscle weakness in the hands. However, if you want it more diagnostic, you can get an EMG or a nerve conduction study to validate this. On exam, depending on kind of the severity of the compression, you may have a positive Froment sign, which is when you have the patient squeeze a piece of paper in between their thumb and hand. Usually, if you have strong abductor pollicis longus, it will kind of, the thumb will remain flat because that's the primary pincer. If that's weakened because the ulnar neuropathy, the FPL, the flexor pollicis longus, takes over, and you get more of a flexed IP, as you can see in that picture. You also have kind of what's called the Wartenberg sign, where you have the patient actively abduct their fingers and then bring them back into adduction. they should all come back. But if that fifth digit remains abducted, that's also a sign that you could have a cubital tunnel impingement. As far as things you can do with dynamic ultrasound, you can see if there's any subluxation, which can be seen in the middle row. So the top row is what if you go from elbow extension into flexion, that nerve will move up towards the medial epicondyle, but should stay within this groove. If it's a subluxation, the nerve will move onto the top medial epicondyle, but won't snap over it. And then actually, if it dislocates, it will go the whole way over. Management initially is going to be nighttime splinting. Again, when you have that fetal position at nighttime, it puts increased strain at the nerve, where an extension splint can offload that. And then if they're doing a lot of activities that require repetitive flexion of their elbow, trying to nullify that. A perineural injection can be diagnostic as well as therapeutic. And then ultimately, if these fail, referring them to a hand surgeon to do an ulnar nerve decompression and transposition, where they essentially dissect down the nerve, kind of bring it out of the cubital tunnel, and then suture it back down so it doesn't continuously snap in that area. Next type injury about the elbow we consider is a radial tunnel syndrome. Much less common. It's a compression of the posterior interosseous nerve, specifically the type 4 fibers of this nerve. And the reason I bring this up is even though the PIN is a motor nerve, there's no weakness due to this compression. They might cause weakness because of pain, but there's no true motor weakness. If there's true motor weakness, it can be what's called PIN syndrome, which is a more distal compression. But typically with radial nerve, it's going to be complaints of just pain, maybe numbness and tingling throughout their dorso-radial forearm. They may have increased some tenderness about 5 centimeters below the lateral epicondyle within the supinator muscle mass. And so again, think back with lateral epicondylitis, we said they should be tender right at the lateral epicondyle, and that proximal extensor tendon. If they're not, they're more in the kind of the proximal kind of that muscle bulk. You may want to, and they're complaining of kind of pain and paresthesias. You want to think more of potential radial tunnel syndrome. Or in patients that are saying, hey, I've been treated for years for lateral epicondylopathy and nothing ever gets better. That's something I'll should cue into this as being a potential cause. And then with resisted supination, as that supinator muscle contracts, this may also aggravate the symptoms. Because of the type of fibers that are compressed, an EMG is not helpful. One of the ways we can assess for this is you can do a ultrasound-guided perineural injection to see if it gives them relief. Then you can follow it up with, or you can do just like a perineural CSI for both diagnostic and therapeutic purposes. If this responds to it and then symptoms were to come back, a hand surgeon can then do a radial tunnel release. And the last nerve impingement in the kind of proximal arm is going to be the pronator teres syndrome. This is where the median nerve gets compressed proximally between the ulnar and humeral heads. Very rare with this. It's thought to be forceful pronation. So hitting racket sports, large forearm muscles. So someone's a laborer, power lifter, a baker, where they're really hypertrophying those forearm muscles. What they're going to complain of is like carpal tunnel syndromes, but more proximally. So anterior forearm pain, paresthesias that radiate throughout the forearm into the wrist. The Tinel sign may be present more proximally, but then it should be negative at the wrist. Treatment's going to be, rest. You could do a perineural injection, and then eventually surgical decompression for recalcitrant cases. Moving on with a distal biceps tendon avulsion. This is thought to be due to an acute excessive eccentric load. So someone's doing lifting something heavy, or they're lifting walking a dog and the leash pulls really quickly. It could cause that tendon to snap off. As far as all biceps ruptures, 90% are proximal, so that under 10% of this distal component. Risk factors: smokers, Men in their kind of 40s and 50s, and especially if they're taking anabolic steroids, that's puts you in a high risk. Pain, weakness with supination. They're gonna have weakness of flexion, but really with supination is gonna see how you test them out. They may have this reverse Popeye deformity where the bicep muscle kind of lifts proximally. And then you can do what's called a hook test, or you grab your index finger, you palpate where their distal biceps tendon crosses the elbow joint, and you should be able to hook your finger behind it. In an acute tear, a lot of times there's a lot of edema, and there's no really tendon that you can palpate, so that's considered a positive test. And then you want to get an MRI stat, essentially to assess for the extent of the tear. Because if it's a partial tear, it can be done with non-operative management. But an acute full thickness tear, typically this is going to require urgent surgery within 2 to 3 weeks. Again, for the partial tears, PRP can be considered to augment the rehab and physical therapy to just restore some of the strength and functioning. However, someone that's young, active, this is something you want to get call a surgeon right away to get them set up, kind of more urgent surgical repair. As far as injuries go, this is something that needs seen sooner rather than later. If they're a low demand or an older individual, sedentary, you can consider doing non-operative treatment for a full thickness tear. You just want to counsel them. They'll lose about 50% of their supination strength and about 30% of their flexion strength. With valgus extension overload, that's the terminology that's a lot of times used in kind of the adolescent population with athletes and throwers. But this can occur, more, for an older population as well, might be referred to as posterior impingement. You'll have pain over the posterior medial aspect of the elbow that's worse with forced extension. Typically, again, in throwing sports, but other sports that do forced extension of the elbow, like volleyball or gymnastics. Positive armbar test, which can be seen here. You have the patient kind of pronate, and then you put a downward force along the elbow to really cause that olecranon and its fossa to engage, can reproduce the symptoms. X-ray may show osteophytes or loose bodies. If you get an MRI, it's going to show some bone marrow edema. During in-season for athletes, management, might have to shut them down for roughly 2 weeks. NSAIDs. You could consider a steroid injection, depending on their age, to kind of get them through the rest of the season. However, this becomes more of a chronic issue. Sometimes the activity restriction has to be several months, followed by a return to throwing program, and then ultimately may require an osteophyte resection and potentially an ulnar nerve decompression if that's also affecting them. Lastly, for the elbow, olecranon bursitis. So this is the most common superficial bursitis, more common in males between 30 and 60. Anything that has a lot of repetitive contact with hard surfaces puts someone at risk. So in the sporting community, wrestlers, MMA, volleyball, diving on the ground. Of these, about 80-90% are aseptic. The remaining may be due to septic bursitis. From the aseptic standpoint, again, you think either acute trauma or repetitive micro trauma, and also things like gout can also manifest as this. What their patients have been complaining about is typically pain and swelling on the posterior aspect of the elbow. Tenderness can be misleading. A lot of times, if it's just from these kind of chronic micro tears, the chronic repetitive trauma, it won't be that tender. Whereas if they're more from like a septic source, they tend to be more tender to touch. If there's erythema or warmth present, again, they may be considered more of a septic source. The way to differentiate between kind of septic bursitis and septic arthritis is they still should have preserved range of motion. So with the bursitis, they'll be able to move their elbow. It may be uncomfortable just from that pressure component. Whereas if a septic arthritis, they're going to be guarding and refusing even passive range of motion. From an aseptic standpoint, really the treatment is going to be, the biggest thing is compression and time. Icing it, NSAIDs to address the pain. But the studies have shown that, at at 1 month out, whether you just do a compression, aspiration, or aspiration with steroid injection, there's no difference between those groups. So a lot of times if someone comes in acutely, unless it's restricting their motion from the compression, I always have them do compression for a few weeks and then follow back up if it's not getting better. And then if like 3 or 4 weeks goes by and they're still having a large collection of fluid, we'll offer aspiration. I very rarely will inject steroid at this site. If you're concerned more for a septic cause, you want to aspirate and send for fluid studies. Most commonly it's going to be MRSA as the cause. One thing to keep in mind is with septic joint, if we're considering like a septic arthritis, the white count's going to be like over 20,000 or even 50,000. But for a septic bursitis, the cutoff is 2,000. It's a much more sterile environment. So even a few thousand WBC is considered a positive septic source. Again, you want to start on empiric antibiotics to cover MRSA, and duration typically is be 10 to 14 days. And again, counseling the patient that about 25% are going to have persistent swelling at 8 weeks. And even at 6 months, there's going to be some residual swelling. So some patients will come back. I've seen where you'll drain it and they'll come back a few weeks later and say, oh yeah, it's back again. Where I think if you can give that information up front and just say, hey, just give it time, keep doing the compression. Most will resolve, but there is always some folks that always have kind of a residual collection of fluid there. Moving on to the wrist injuries, we're going to talk about some intersection syndrome, Wartenberg's, de Quervain's, which is probably the most common one that we'll see in clinic. And then a couple of nerve impingements, carpal tunnel ulnar canal syndrome. A brief review of wrist anatomy with extension to about 70 degrees, flexion to 80 degrees, ulnar deviation to 30, radial deviation to 20. There's 3 articulations, a radiocarpal, ulnar carpal, and distal-radial-ulnar. There's a lot more ligaments. I didn't kind of review them all here compared to like the elbow. Biggest thing for be in mind for boards is you should know these compartments, the 6 dorsal compartments kind of off by heart. The first is going to be your EPB and APL. Your second is going to be your ECRL and ECRB. Third is your EPL. Your fourth is your extensor digitorum and indices. Your fifth is your extensor digiti minimi. And your sixth is your extensor carpi ulnaris. And a lot of these are important when we start talking about some of the conditions in a few moments. And so in recalling which of these compartments contains what is going to be paramount to some of your questions on your boards. Briefly with wrist ultrasound, your home base on the dorsum of the wrist is going to be this Lister's tubercle. The first, this is going to be the second, and then the first is down here further compartments on one side, and the third through sixth are on the other side. And then from the home base on your ultrasound on the anterior aspect, you want to see your median nerve, your superficial digitorum, the profundus. The only other tendon that's in the carpal tunnel is going to be your FPL. So as far as conditions go, intersection syndrome, this is one you'll definitely see mentioned on boards. Historically, it's been thought there's been just like one type of intersection. However, some of the questions will differentiate between like a proximal and a distal. The proximal, which again is the more historical one, it's where the first dorsal compartment crosses over the second dorsal compartment about the level of the Lister's tubercle. So when you're scanning with ultrasound, you actually can see those tendon fascial planes cross over one another. The kind of more nuanced one is this distal intersection syndrome. And this is where the third dorsal compartment intersects or bypasses over the second one, and that's going to be distal to the Lister's tubercle, closer to the actual wrist joint itself. A lot of repetitive wrist extensions put someone at risk for this. So, weightlifters, if they're doing like things like snatches, rowing, again, that repetitive pulling, and then gymnastics, heavy landing, back handsprings, things of that nature, forcing that wrist extension. Or someone that does a lot of push-ups, again, that just kind of pushes that wrist into extension. It's a clinical diagnosis. One thing you can do with ultrasound is you can kind of sono palpation, say, hey, is this the site that bothers you? If an MRI is obtained, you may see some peritendinous edema. There may be some fluid in between the fascial layers. Treatment's going to be activity modification. So we're limiting kind of the wrist extension, especially like the forced motions. You could consider a brief period of wrist splinting to address that. Anti-inflammatory medication. And then lastly, you can do an ultrasound-guided steroid injection in between those planes where they dissect or bisect one another to reduce the pain. This picture right here, I think, is a good representation of where you would expect the pain. Again, it doesn't extend to the hand. It doesn't go to the ulnar aspect. It really is kind of this localized, kind of, proximal, kind of probably 2 to 5 centimeters from the wrist joint on that dorsal-radial aspect. To juxtapose that graphic to the one for Wartenberg syndrome, where you have dorsal-radial pain of the wrist, but it also extends into the hand. This is due to a compressive neuropathy of the superficial radial nerve. Risks include wrist immobilization. So if someone's been in a cast or a brace for several weeks, especially if it's ill-fitting, classic kind of board question: if someone's putting handcuffs, they'll have complain of pain at this site afterward. Pain and paresthesias and numbness over the dorsal radial hand. No motor weakness, because the superficial radial nerve is a dedicated sensory nerve. They may have a Tinel's or at the site. A Finkelstein's test can actually present this way as well. So something to keep in mind with if you think someone has de Quervain's, but they're not responding to standard treatment, you may want to go back and think of Wartenberg's, especially if their primary complaint is like a numbness or paresthesia. You can do a lidocaine injection for diagnostic purposes, and then treatment's going to be rest, just give it time, or you could consider doing an injection perinaturally. De Quervain's tenosynovitis, very common wrist complaint. This is going to be inflammation within the first dorsal compartment. So again, affecting that APL and EPB tendons. Women are more commonly affected than men. Repetitive wrist motion with ulnar deviation is what tends to cause this. One of the things you'll see is a lot anecdotally, postpartum females, you'll see this commonly in. My rationale is you're holding a baby, which is something you kind of doing for the first time, or lifting a car seat that puts that kind of forced strain. If you ever lifted a car seat up with a kid in it, for some reason it feels 100 pounds more heavier than when you lift the kid out of it. But it kind of forces that wrist into dorsiflexion. So one thing when you're talking about treatment and mechanics, if they are someone's postpartum, I always try to hey, when you're lifting a car seat, hook it around your forearm instead of grabbing at the hand. As far as presentation, they're going to plan a very focal tenderness over the radial kind of aspect of the wrist. They'll have that positive Finkelstein's, which is seen the test in the top graphic. Another test, you can just kind of have them resist abduction, abduction, or extension of their thumb. If you do an ultrasound in clinic, you'll see some anechoic fluid within that tendon sheath. Treatment, activity modification, like we just mentioned, thumb spica splinting, and NSAIDs. Patients have a really high response rate to ultrasound-guided CSIs within the tendon sheath. I would say this is probably, of all the kind of tendinitis things I see, this is the one I probably offer an injection soonest, just because I do think it does have the best results addressing that acute pain. Typically, I'll recommend doing a steroid injection and then putting in a thumb spica splint for about 2 to 3 weeks to really let that kind of tendon inflammation resolve. And then if it fails with these on-off treatments, a first dorsal compartment release is on the table. TFCC injuries are found on the ulnar side of the wrist. Several components of the TFCC to include the meniscus homolog, the ECU subsheath, and then there's our central articular disc. These types of injuries are then kind of spaced out to either type 1, which is an acute traumatic, versus type 2, which is degenerative. And then type 2 is then further divided in based on its location. Patients are complaining of ulnar-sided wrist pain that is worse in ulnar deviation. The most specific finding is a fovea sign. So if you compress in a little soft space between the ulnar styloid and the carpal bones, having pain there is the fovea sign. Then you can do what's called a TFCC compression test, where you basically have them forcefully alternately deviate to see if it aggravates the pain. A tension test, where then you radial deviate and see if it causes pain on the ulnar aspect of the wrist. And also what's called the push-off test, where you have the patient essentially kind of scoot onto the edge of their chair and try to push off to stand using that one hand to use its weighting or weight bearing. X-rays likely going to be negative. However, you may have this positive ulnar variance where the ulna sits more distal to the radius instead of even plane. That puts them at risk for more of a kind of a chronic injury. These TFCCs can also be associated more from an acute standpoint with a distal radius fracture. So keep that in mind if you're treating someone with a distal radius fracture and the fracture's healed up and they're still complaining of wrist pain, especially if that pain's shifted more to the ulnar aspect. You may want to consider a TFCC injury. MRI is kind of the diagnostic standard for this. With that said, if you do get an MRI that's normal and you're still highly concerned, you can get an MR arthrogram, which adds sensitivity. The initial treatment is going to be with pretty straightforward immobilization, NSAIDs, a steroid injection into the ulnar carpal joint can be beneficial. There's not much data on the use of PRP. I have seen it done when I was in fellowship, but I've never personally have done that myself since then, and I couldn't find much data to support its use. If it's recalcitrant at these above measures, referring to a hand surgeon, they almost treat it like a meniscal tear. That's going to be mentioned that has like a meniscus homolog, but they'll do an arthroscopy to address it. Moving on, we have kind of ECU subluxation versus dislocation. So the ECU is the most ulnar of the dorsal compartments. It's almost towards like almost the really lateral aspect of that wrist, the ulnar aspect of the wrist. What happens as you move from pronation into supination? That tendon can either sublux and move outside the tendon sheath, and then as you pronate back in, reduce back into the subsheath, or it can dislocate where it just stays out of the subsheath altogether. Patient will complain of this like snapping sensation. They'll want to show you what's kind of, they'll kind of reproduce it for you in clinic, where they'll kind of pronate, supinate the wrist, and you'll see the tendons keep snapping back and forth. Wrist flexion and supination tend to aggravate the symptoms. You can dynamically assess this on ultrasound. Some pictures below where they look at the ECU within that groove, and then as you move into supination, it will kind of slide over top and sublux, or if it goes further down and dislocate. Treatment is going to be immobilization. Can do an injection for just purely kind of symptom comfort, because sometimes a lot of people will have the snapping, it doesn't bother them, but from time to time it may acutely get inflamed. And that's where like an injection comes in to help with that kind of acute inflammation. However, if it's continually subluxing or dislocating and pain's not going away, arthroscopy, where they'll go and actually reconstruct the tendon sheath, is kind of the definitive treatment. I think our last two slides coming up. So last is going to be kind of your carpal tunnel syndrome. Again, compressive neuropathy of the median nerve. Outside of the median nerve and the carpal tunnel, from the end, this might be tested on your boards, is your FDS and FDP tendons, and the only other tendon is your FPL. There's about 10% incidence this annually. Females more predisposed than males, and typically you're going to see this more in the 4th and 5th decades of life. Anything that can cause kind of retained fluid retention, so hypothyroidism, pregnancy, obesity, put someone at risk for this. Also, repetitive wrist motion, or specifically flexion, is going to aggravate this. Patients are going to complain of pain and numbness in the median nerve distribution. So remember, on the volar aspect of the hand, that's going to affect kind of the first, second, and third, and the radial half of the 4th digit. And on the dorsal aspect, it's going to be the fingertips of those fingers as well. Pain may be provoked overnight, similar to cubital tunnel syndrome. When you're sleeping and kind of that forced flexion, it compresses the nerve. So they might say they wake up in the middle of the night and there's a lot of pain, or first thing in the morning, symptoms are worse off. Yeah, it's a clinical diagnosis. You can get some studies to further assess for that. From a clinical standpoint, in clinic, Perkins compression test is the most specific. That's when you just compress over the line, their median nerves, kind of hold it there about 30 seconds to see if it reproduces the symptoms. You have the Phelan's test, or the kind of the prayer hands test, and then a Tinel is just kind of tapping. Typically, imaging is not necessary unless you want to exclude if there's anything else going on. Ultrasound actually can assist in the diagnosis. So typically the cross-sectional area is less than 9 millimeters squared. So if it's greater than 10, that also points to a potential carpal tunnel syndrome etiology. And there's some scaling systems out there where if it's 10, they'll consider it mild, 11 millimeters squared being moderate, and then greater than 12 is a severe. EMG is going to show prolonged latency, slow conduction times, as well as some fibrillation waves. Initial management is going to be nighttime wrist splinting, oral NSAIDs for pain. Adjunct treatment can be perineural CSI or what's called hydrodissection. With hydrodissection, a lot of stuff, you kind of avoid the steroid. You might do something like sugar water or normal saline. Different studies have shown different things, but most recently, the one that I could found is basically whether you do a perineural CSI versus a hydrodissection using D5W, they're both going to give good symptomatic relief compared to control or kind of sham treatment. And then for refractory cases, you can refer them for carpal tunnel release, which can be done open, or they make an incision and dissect down, as you can see here. That has a higher success rate than endoscopic. Endoscopic, there's always a risk that you can not fully dissect the transverse carpal ligament, and so they may have recurrence of symptoms. Whereas an open, you have less risk of happening, however, higher risk of actually nerve injury. And more kind of newer technology, this is percutaneous release. This is in theory something that we can do from a primary care standpoint. I have never done this. That's not anything that we offer here at UH that I'm aware of. But depending on where you're at and practicing and your relationship with your, hand surgeons, this might something ask you to do. You can see it in this picture. Essentially, it's this device. You insert it from proximal to distal. It has these little balloons that fill up and basically press down the median nerve and lift up the transverse carpal ligament. And it has a little retraction knife. And so as you pull that retraction knife back, it slices the transverse carpal ligament. And so there's much less downtime and recovery because you're making a small incision versus what's necessary for surgery. And lastly, ulnar canal syndrome or Guyon's canal syndrome. This is going to be a compressive neuropathy of the ulnar nerve. The contents in the canal are going to be your ulnar nerve, ulnar artery, and vein. It's split up into 3 zones. So zone 1 is before it bifurcates. This is going to be a mixed sensory and motor dysfunction. Zone 2 is a pure motor dysfunction, and zone 3 is a pure sensory dysfunction. It's also known as kind of a handlebar palsy, that repetitive kind of compression of the ulnar side of the wrist. Other things that can cause it are ganglion cysts or acute fractures of the hamate. On presentation, they may have clawing that's present at the 4th and 5th digits, intrinsic muscle weakness. Similar to cubital tunnel syndrome, you may get a positive Froment sign or a Wartenberg sign. Imaging is not necessary. However, especially if it's an acute injury, you're probably going to get X-rays if you're high concerned for hamate fracture or a CT scan. If an MRI is obtained, it may show a ganglion cyst compressing it. Another thing to consider, again, one of the things that can cause it is an ulnar artery aneurysm. So getting like a Doppler ultrasound to assess for that may be warranted. Treatment, it's basically splitting, activity modifications. Similar to carpal tunnel, you can do a hydrodissection or a CSI. And then refractory cases, you can go to surgery, what they'll offer them, depending on what the cause is, to decompress it. So like a hook up hamate resection. They might do an ulnar nerve embolization, artery embolization, if that's the cause. All right, so that's the lecture. There's a few CAQ questions to go over at the end, if you guys wanted to, if we have a few extra minutes. But does anyone have any questions, anything we talked about today?
Again,
I guess a quick question about carpal tunnel syndrome. So
Sure.
I guess during residency, I was always taught that if there's obvious atrophy or like weakness, to go ahead and refer them to surgeon. Is that something that you would still do at this point, or would you try to do some of the other like hydrodissections and things like that first?
I mean, I think a lot of that's that kind of that whole like shared decision making. If someone actually has like comes in, they're like, "Hey, I'm dropping things in my hand," I do recommend they go to surgery. With that said, if there's someone like I don't want surgery, then I'll offer them non-operative things. So if it's so kind of my so I agree. So if someone has a true like motor weakness, I'm more apt to refer them out sooner than later. The atrophy, by the point they're atrophied, that's been kind of long-standing symptoms. And unfortunately, even after they do the carpal tunnel release, getting that motor strength back, it really is unlikely. So I've even asked some of our hand surgeons before for that very reason. They're like, once they're atrophied, that muscle was kind of shot. So you're never wrong. Again, any of these treatments, you can always offer a consultation. Me personally, unless they're having like true motor weakness, I'll try to at least do non-operatively first for a few weeks, and then if they're not responding, refer them after that.
Makes sense. Thanks.
Mm-hmm. Anyone else? All right. Couple quick questions just to kind of reinforce what we talked about. So with a 37-year-old golfer, right dorsal forearm pain with activity for the past 3 months. On exam, tender over the radial head. There is minimal wrist extensor weakness or pain. Forearm supination provokes the symptoms. X-rays are negative. Symptoms have basically failed to resolve with treatment for lateral epicondylitis. What other diagnosis do you want to consider? Anyone can answer. Any thoughts?
Would it be radial tunnel syndrome?
Yeah, exactly. So this question stem is basically saying, hey, they've been treated for lateral epicondylopathy. It's not responding. They're not really having weakness. The forearm supination provokes it. Remember, that's where the impingement typically happens, is in the supinator muscle mass. So that's what that question is kind of getting at. All right. A 30-year-old patient presents with right wrist pain. They fell onto an outstretched hand during a tennis match. Pain is worse along the ulnar aspect of the wrist, where they perceive a painful kind of clicking sensation. On exam, there's tenderness between the ulnar styloid and pisiform. It's worsened with ulnar deviation and resisted supination and pronation. What is the most likely cause you're thinking of here?
Is that a TFCC?
It is. So again, things you're looking at is ulnar aspect of the wrist. So you're not really worried about like ECU dislocation. These others remain in play. The biggest thing is perceived kind of clicking sensation. Because it is almost like similar to a meniscus, the meniscus homologue. So as patients come up for meniscal injuries, they need to have this painful clicking. You're gonna have this painful click in the wrist. And the big thing is this pain tenderness we're looking at is the fovea sign. I think it's my last one, I believe. So an 18-year-old college gymnast presents in the training room with wrist pain. Pain is along the dorsal wrist, just proximal to carpal row. It's provoked with a wrist extension. You diagnosed the patient with intersection syndrome. Which of these tendons are most commonly involved? So you guys got to think back to those dorsal compartments and which are the compartments involved. It's gonna be four of the 6 choices are the answer.
Can I cheat? Is the recent CAQ taker?
Sure, absolutely.
I think it's ABEF, first and second compartment.
Yes, correct. Yeah. So again, just to kind of rehash, the classic intersection syndrome is going to be the second compartment over the first compartment at the level of the Lister's tubercle. That might be some of the CAQ books refer to this as a proximal intersection syndrome. So yes, kind of keep that in mind. Part of the proximal versus distal that it might pop up. All right, that is all I have today.
Thanks, Josh. I gotta hop up and start with the applicants.
Yeah, absolutely. Well, any questions ever come up? I think this is recorded, so don't hesitate to reach out. You'll have a nice Friday and a nice weekend.